treatment and some of the experience we have in our hospital of managing this. So this is a sort of an agenda of the next 10 minutes. So let's go straight into the nitty-gritty and talk about the causes of pain. So I think when we look at mechanical causes of postprandial pain, we can divide this anatomically into where we are. So if we look at the actual Roux-en-Y gastric pouch, or even the gastric remnant, the section of the stomach that's been bypassed, things that are maybe responsible for chronic postprandial pain include obviously, ulcer disease, either in the pouch as a marginal ulcer, but even sometimes people have found peptic ulcers in the gastric remnant. You can have a stricture at the GJ, a gastric fistula, and certainly reflux disease and hiatus hernias can also cause symptoms giving rise to postprandial pain. Some of the more uncommon findings are the so-called blind end of the ruling at the gastroduodenostomy, so-called candy cane syndrome. Some studies have found the presence of foreign bodies, such as a suture or a staple, within the pouch, and when you remove them, suddenly the pain goes away. So just something to think about. And lastly, as I mentioned, you can have an ulcer on the remnant side. Moving down the pouch, you have the ruling, and here we have to obviously think of conditions like internal hernias, port-side hernias, adhesions or kinks, which may be responsible, and less commonly intussusception. I'm not aware of anyone who on purpose does an antiperistaltic ruling, but that also has been, if you find that that's the case, then that might be a cause of postprandial pain. One obviously quite common cause of postprandial pain is biliary disease. So certainly, I think most patients you'll see will get an ultrasound scan at some stage to exclude gallstones, and that of course can lead to different manifestations of gallstone disease. But one thing that we shouldn't forget is some patients can present with sphincter of Oddi dysfunction, and just because they've had bariatric surgery doesn't make them immune from that. So you have to think sometimes outside the box and investigate them for that, which is obviously quite difficult when you've had a Roux-en-Y bypass, is how you're going to access the sphincter of Oddi for sphincter of Oddi manometry. And then other issues to consider are, for example, people who've had a mental torsion or infarction, and then obviously some of the more rare syndromes associated with massive weight loss, such as superior mesenteric artery syndrome and linear artery syndrome. One must not forget and always keep in mind non-mechanical issues. So, for example, functional disorders, patients who present with, for example, colonic transit problems, constipation, irritable bowel syndrome, and even dumping syndrome can sometimes manifest with pain and discomfort. And also you have the whole situation with different esophageal motility disorders can also cause these symptoms. And looking at behavioral and nutritional problems, those persons with overeating or eating too quickly, they can present with pain. And some may develop food intolerance, such as lactose intolerance, and they can end up with postprandial pain on eating or drinking milk rather. And lastly, of course, there is SIBO, a small intestinal bacterial overgrowth, which can also present with discomfort. So how do we try and work out what the answer is when you've got about a differential diagnosis of 60 or 70 different potential diagnoses? So I think the first thing is to involve your MDT. I think that's really key, and involve each and every member of the team. And certainly, I think one thing to really look at very carefully is taking a history, and that's obviously very important when you're considering causes of functional pain. So it may be apparent from taking a dietetic history that if the patient says that if you find that they're eating too quickly, then that's obviously maybe partly responsible for some of the symptoms. And of course, there may be some patients who find that they get symptoms when they only eat one particular kind of food, and that might suggest they might have a gluten intolerance. So the key thing is to take a detailed dietary history and certainly involve your dietitians. Those patients, of course, who may have some issues with colonic transit, may have chronic constipation, again, that you will probably pick up from a detailed history. And also, those patients who are getting these postprandial pain attacks after eating, high-carb foods may well be getting it due to an element of dumping syndrome, and they may also exhibit other symptoms of dumping in addition to pain as well. So I think the key thing really is involve your whole team. You really need help from everybody, from your psychologists, psychiatrists, dietitians, gastroenterologists, obesity physicians, specialist nurse, and also a pain specialist. Now, in terms of investigations to try and decipher what the if it's a mechanical problem, I think there are some things that all these patients will need. And it's not a question of choosing one or two. You probably end up needing to do most of these tests. Clearly, an ultrasound scan to look for gallstones, or if you suspect, a problem with the biliary system, then an MRCP scan. A CT scan is probably going to be mandatory for most patients to exclude, for example, things like internal hernias, bowel obstructions, or port-side hernias. Barium swallow meal can again be extremely helpful trying to identify if there's any issues with the pouch or pouch emptying or the gastric jejunostomy. And often it's best to be there with the radiologist and ask for a textured phase or a solid phase barium meal. And one thing that we really like to do is to be in the X-ray suite and actually try and work out in real time when the patient is getting pain and how it correlates with the images we see during the solid phase barium meal. Endoscopy, I think, is again pretty mandatory. It will show up things that the other X-rays may not show up. And if all these, if the three tests I just mentioned don't reveal anything, then I think you are pretty much bound to do a diagnostic laparoscopy as an investigation, because there are some things that just won't show up on X-rays or endoscopy, and it's usually part of the hierarchy to investigate with diagnostic laparoscopy. Now, if that comes up negative, you're kind of running out of causes for pain, and assuming it's not a functional disorder, then you're going to have to start looking at things like esophageal manometry to see if there's a motility disorder that's causing pain or discomfort. Options for treatment, so sort of, should we say, medical or conservative treatments. Obviously, it depends on what the cause is. So if it's maladaptive eating behaviors, then you need to put in some behavioral modification to help with that. And if it's a question of this particular kind of food, then avoiding that kind of food. So it's pretty, if you know what's causing it, it's not difficult to treat if it's one of these things. Going back to the benefit of using diagnostic laparoscopies, in this particular study, they found that about 40% of patients with chronic postprandial pain ended up needing a diagnostic laparoscopy. And in this particular study, 70% ended up finding, in 70% of the patients who had the laparoscopy, they got a diagnosis of why these patients were having abdominal pain. So what about things that we can do as surgeons to treat chronic postprandial pain? Well, obviously it depends on what the cause is, so there's no sort of magic formula. It's pretty obvious. If you identify what the cause is, then you basically go ahead and treat that. And if all else fails, the question is, do you reverse your Roux-en-Y gastric bypass? So in this particular study by Shikora, they looked at all the causes for reversal. So they had to reverse 19 patients who had undergone Roux-en-Y, and 5 of the 19 were that because these patients were having chronic postprandial pain. Now, in this report, they didn't actually mention if those 5 who had the reversal got better or not, but you can see that if everything else fails, then you may well have to propose to the patient to reverse their Roux-en-Y gastric bypass. And then the final part of this talk, I'm just going to mention a little bit about our own experience at my hospital with this condition. So the technique we follow is a standard Roux-en-Y anticoagulant antigastric with in-hospital follow-up at 3, 6, 12, 24 months, and then discharge to GP yearly follow-up. The follow-up process, like most hospitals, is led by our specialist nurses, dietitians, and if they pick up on follow-up that there is a patient with post-bypass abdominal pain, they automatically send them for investigations. The investigations are done, and then the patient comes to a surgical clinic for evaluation. So the investigations that we do as a matter of routine for these patients, as mentioned in the main part of the talk, are ultrasound, CT, barium, endoscopy, and then in selected cases, if the aforementioned are negative, then we go ahead with the pH manometry. So I'm going to give you a little bit of what we have. So we collected data from 1,295 Roux-en-Y cases, and we identified 92 cases of postprandial pain. This is the gender breakdown, so it's mostly female, but that just reflects the majority of our patients who have bariatric surgery, and you can see other demographic factors. The median weight loss in the patients who had the pain is 38 kilograms. So you would have thought that the patients who have chronic postprandial pain may lose more weight than your normal set of patients, but we didn't find that was significant. And these are the investigations they underwent, as explained before. Some of them obviously underwent all of them. And this is quite an interesting study, an interesting graph. It shows you for each investigation we did, whether it's ultrasound, CT, barium, endoscopy, the number of positive results we got. So the pickup rate, I would say, on average is about 40 to 50% per investigation type. 75 out of those 92 patients actually ended up having a diagnostic laparoscopy as well. And this bar chart tells you what we did at the diagnostic laparoscopy, apart from just putting a scope in. So a proportion had a cholecystectomy, some of them had a candy cane removal, some had internal hernia spaces that we closed, some had a candy cane at the JJ, so-called JJ blind vein removed. A majority had a combination of different things done, and a few had nothing done. 7 out of 92 patients ended up having, on another occasion, returning for a reversal of the Roux-en-Y gastric bypass. So that's a 9% reversal rate. This chart shows you the effect of the intervention. So in green, you'll see how many of the symptoms of postprandial pain resolved. So when you do a cholecystectomy for gallstones, some of them will get the resolution of their symptoms. We can see it's not 100% resolution in symptoms regardless of what you do. So overall, you can average this out to about 26% resolution of postprandial pain. Now this is an interesting slide. It tells you about the predictive factors. So we went back in those 92 patients and we looked at their initial histories, and we did a bit of regression analysis to see if there were any factors in their preoperative condition which could predict ended up with postprandial pain. And not surprisingly, I suppose you could say a small proportion had a history of depression, a small proportion had a history of preoperative pain. So for us, those are flags. So now when we have somebody who comes to us with pre-existing chronic pain conditions, for example, whether it's fibromyalgia or something else, or they're heavy users of painkillers, narcotics, we tend to dissuade them from having bypasses and instead, would prefer to do maybe a sleep or something else. So, to end, ladies and gentlemen, in the literature, about 7% of patients with reported abdominal pain have, or rather 7% have a chronic postprandial pain after bypass. Pre-existing pain and depression are risk factors as identified in our study, and other associations described in other papers include young age, preoperative symptoms, unemployment, and people coming in for revisional surgery. And I think the key point here is really involve the whole of your MDT when dealing with this difficult set of patients. The final slide, this is super busy, so I apologize for this, but this kind of gives you a little bit of a schematic on dealing with postprandial pain in your clinics. So it just summarizes the talk. And I'm happy to answer any questions. Thank you very much.
Thank you so much for a nice talk. Any questions from the floor, please?
Very nice talk. I wanted to know the results of candy cane removal. What were the outcomes after candy cane removal?
Yeah, I mean, I can go back.
That's commonly blamed for
can we go back? It's in the bar chart. From memory, it's about a 30-35% resolution of pain. Yeah, it's like I'll show you.
And when would you consider a CAD significant enough to remove?
Good question.
Variant, you would have done a variant.
Yeah, but even the variant sometimes, because it's two-dimensional, you can't see. So usually you pick them up. Even the variant isn't spotted. Thank you. You pick it up on laparoscopy. Yeah, but I mean, they typically say anything more than 5 centimeters is pathological, but it's really hard to measure it correctly, I think, on barium. But I'll show you this. There we go. Right, this is it. So CC is the candy cane. So you can see from this, roughly, it's about a third. If you see a third get resolution.
I'm Ahmed.
Sorry.
Really good talk, thank you very much. A problem which I think all bariatric surgeons will recognise. A couple of things of our own patients, I'd add in interception, I think probably is more of a problem than we realise it is. But it's very difficult to catch, because if the patient hasn't got the symptoms when they have the investigation, then you'll miss it. And we've got quite a few opiate users with constipation that on naloxone now that seems to help. But my question is, why is this not been caught on by band sleeve trial, do you think? Because this is a major problem for our patients, but the results of band sleeve suggest that it's not affecting patient quality of life.
Yeah, I mean, the band sleeve, I mean, so all I can say is that they haven't obviously published the final kind of talk, so we've all heard some of the abstract discussions. So I think, they when we see the final manuscript, and obviously Jim is here from the team, and maybe he has more information about the incidence of chronic postprandial pain in the bypass patients. But I agree. I don't know if it's captured it or not. Jim?
The written report is 100 pages long, and there's data and data and data. So all we have seen, it's one of the comments I made yesterday, is the headline figures in terms of weight loss, quality of life. All of this data is there. There's data around how many people I'm interested in complications and the side effects, because I think there's the upside, and the upside is now reasonably clear in everyone's mind, and there's all of these downsides, functional problems, nutritional problems, etc., some of which will be clear, and again, it's just for 3 years, so it's there, it's just going to take a while to digest.
Sorry, Ahmed, great talk, thank you very much, very interesting. Since the diagnostic laparoscopy is the main investigation and the treatment in this group of the patient, would you recommend an early consideration of diagnostic laparoscopy and proceed? I have seen in my practice many of these patients, poor patients, going for lots of investigations, and everybody bring them right and left, refer to gastro, do that. And I think if we start with diagnostic laparoscopy, consider it early in the management, that will help them.
Yeah, I think that's a fair point, and I think you could actually make a case for just doing an ultrasound to look for gallstones, because it's going to be hard to do that during a laparoscopy unless you have those laparoscopic ultrasound. But you could potentially just do an ultrasound to look for gallstones and then go straight to laparoscopy and basically consent the patient to fix everything. So if you see internal hernia space, you close it. If you see a candy cane, you chop it off. If there's stones in the gallbladder, you take it out. So basically, do everything. That could be a kind of a way of dealing with this problem.
Absolutely, thank you.
Jim?
Right. I mean, the JJ anastomosis, I do think, is a bit of a mystery. And how do you have experience of revising the JJ, and so what? Yeah, just be interested, or from the panel.
Yes, I mean, with the JJs, so when we go in and we see a blind limb at the JJ, because sometimes you see a little bit of, again, it depends on how you do a JJ, but the way I do it, sometimes we have a little blind end to the JJ and you see it's kind of swollen, it doesn't look happy, it's like almost a tracking gas. So it's quite easy just to, staple it off. Now, if you want to redo the whole JJ, that's a bit more complicated, because you have to basically staple it off and then redo 2 anastomoses. But if you suspect there's a kink or a problem, then I think you're pretty much forced to do that.
Yeah, that's important, because in the JJ there is also candy cane, sometimes a very long one. And the most than that, there are people seeking, and including myself, that this can be the measure cause of pain after gastric bypass, because there is a lateral anastomosis, a big one, that in the end will end in a big anastomotic lake with stasis at that level and implying in the drainage to the bowel. So what we think about is that the lateral, terminal lateral, and JJs. And to side.
Yeah, I mean, I think it's a way of preventing a problem, but yeah. Kevin, what is your experience?
There is no side behind that.
Yeah, I agree with this, and we changed due to the fact that without any exception, at the JJ anastomosis, there is a big lake there. And you can see radiologically in almost all the patients, if you originally prefer the side-to-side anastomosis, especially in double stated technique. But and the scientist seems that it's working well, and the manual one, it's decreasing the cost too. So it can be an option.